All right, welcome and thank you for being here today. My name is Kayla and I am with the Metro Council. If you're not familiar, the Metro Council is the Metropolitan Council of Community Mental Health Centers, and it's a collaborative membership organization representing the public mental health system of community behavioral health centers serving the greater KC area. We provide support to our member organizations, as well as education, information, and resources to the public on accessing quality health services. We host the Mental Health KC conference every May. Hopefully some of you have been with us in the past. And then we also provide free webinars like you're joining today on the second and fourth Thursday of every month. We do have something exciting happening later this month. Please save the date for our summer workshop meeting college mental health needs on July 31st. That's going to be from 9:30 to 3:30 at Johnson County Arts and Heritage Center. Registration is live now, so I will drop the link to that in the chat. The cost is only $15. That does include your lunch as well as 5 contact hours if you need those. Then a quick reminder before we get started, the views and opinions expressed today are those of the speaker and don't necessarily represent the opinions of Metro Council. And at the end of today's webinar, I will put a link and a password to get your certificate of attendance for today's webinar. With that, I am very excited to introduce Elena, and I will go ahead and hand things over to her and she can go ahead and introduce herself. Thanks for being here, Elena.
Thank you so much, Kayla, and thank you for having me, and thank you to everyone who's joining us today. So I'm going to go ahead and start sharing my screen. So my name is Elena Horvath. I am the program manager for Missouri's Maternal Health Access Project, and today I will be presenting on behalf of both MHAP and the Missouri Child Psychiatry Access Project, MO-CPAP. I know that some of y'all might be joining us from Kansas, so I do want to give a quick plug. Everything that I talk about today for MHAP and MO-CPAP, there is a similar version of these programs in Kansas. It's called Kansas Connecting Communities. It is absolutely wonderful. So if you get excited about any of these resources, they exist in your state as well. So today, like I said, we'll be talking about Missouri Psychiatry Access Programs. And specifically how these programs can help bridge the gap that exists between the need for mental behavioral health care for pregnant, postpartum, and pediatric populations in Missouri, and the kind of lack of resources and infrastructure that exists. I will do my absolute best to monitor the Q&A bucket or the chat for the duration of this webinar, so feel free to drop questions in as you go. But I'm also going to try to save about 10 minutes at the end for questions. And also anyone can feel free to interrupt me, I think, if there are questions that I have missed. So we're going to go through kind of like 4 different sections to this presentation today. So I like to start by kind of level setting, providing some definitions and statistics around perinatal mental health in Missouri specifically. Then we will turn a little bit to pediatric mental health, and then I will spend the bulk of the presentation talking about MHAP, MO-CPAP, what we are, what we do, how we can help, and then end with a little bit of information about the impact that we have had so far. Our programs are funded by the Missouri Department of Health and Senior Services, and then also we both have grants through HRSA, so just want to take a second to acknowledge that funding and give a huge thank you to those agencies for supporting this work. And then jumping into perinatal mental health, first broadly and then Missouri specifically. So throughout this presentation, I'm going to say perinatal mental and behavioral health over and over and over again. And when I say that, what I am referring to is any mental or behavioral condition occurring either during pregnancy or in the first 12 months postpartum. I am not limiting that just to conditions that arise kind of as a result of the pregnancy or postpartum experience. If someone has been struggling with depression or anxiety for years and years, getting pregnant is probably not just going to make that go away. So any pre-existing conditions also fall into that perinatal mental health bucket. I'm also going to be using the phrase PMADS throughout this presentation, and I know this is probably a review for a lot of you, but again, just to level set, make sure we're all on the same page with our definitions. PMADS are perinatal mood and anxiety disorders. So that refers to, again, P, perinatal, anything during pregnancy or those 12 months postpartum. Mood disorders such as depression, bipolar disorder, or psychosis. The full spectrum of anxiety disorders, including but not limited to generalized anxiety disorder, panic disorder, obsessive compulsive disorder, and post-traumatic stress disorder. We won't talk about it today, but a huge proportion of women report having trauma from their birth experience. So PTSD is a crucial piece of the PMAD puzzle. And then the D, disorders, daily functioning is impacted by these symptoms. So PMADs and substance use disorders are among the most common obstetric complications, if not the number one most common. It is estimated that based on the data we have, 1 in 5 women will experience a PMAD. And this is not necessarily relevant to the rest of the presentation, but I like to use my little soapbox to share some information, so there will be some of that sprinkled throughout. 1 in 10 men will also experience a PMAD. So we tend to think about mostly the mom during this period, all of the hormonal changes, the physical changes, the giant life changes, but the dads that you're working with are also vulnerable to experiencing these perinatal mood and anxiety disorders. They've also had a major life disruption. They're also in a vulnerable position. So I just like to highlight they're extremely common in women, but they're also fairly common in men. So we know that perinatal mood and anxiety disorders and perinatal behavioral health conditions are super common, but we also know that they are routinely underdiagnosed, and then even when they do get a diagnosis, they are routinely undertreated. So there are a lot of reasons for this, and I'm going to oversimplify a little bit. There is, of course, the element of stigma and maybe folks' reluctance to share the symptoms that they're experiencing. There are all these myths around pregnancy and the postpartum period, like you will fall in love with your baby immediately and it will be the happiest days of your life and it will come to you naturally. And that's not the reality for a lot of people, but we see these kind of like glossy images of the pregnancy experience on social media. And then when that's not what we experience, we can feel an even greater sense of shame about it. So there's obviously the stigma associated with mental health in general, and then kind of the added layer of that, the motherhood myths and the pregnancy imagery that we see. But I don't want to pin this slide on stigma alone. We also know that there just isn't the workforce or the infrastructure in place in Missouri, in Kansas, in the United States to provide the level of treatment that is necessary to meet the needs of 1 in 5 women. We call our perinatal psychiatrists unicorns. There are so few of them in the state of Missouri, and they're really concentrated around St. Louis, Kansas City, maybe a couple in Columbia. But the rest of the state is a perinatal psychiatry desert. So even if we are getting a positive screen for perinatal depression or something like that, the question is always what next? We know there's a problem, but where are the resources to treat the problem? And that will be a lot of what MHAP is trying to address. But it's really important that if we do have a perinatal mental or behavioral health condition, mom gets treatment for it. So this slide doesn't talk about the experience of mom struggling with these disorders and how painful and scary and dangerous that can be. But that's a really key piece of the puzzle. But even looking beyond mom's experience, untreated perinatal mental and behavioral health conditions can have really negative impacts on a lot of different things. So this is not an exhaustive slide, but I do want to just illustrate a little bit what can happen if we're not getting mom the treatment that she needs during pregnancy and postpartum. There can be adverse impacts on pregnancy and birth outcomes. So we see a higher rate of preeclampsia, a higher likelihood of preterm delivery or low birth weight, and also more NICU admissions. There are adverse impacts on the relationship between mom and baby. So it can impact her ability to breastfeed, it can impact her ability to bond with baby, and it can also impact her relationship with her partner. And then finally, we see a lot of downstream impacts on the child. Cognitive delays, motor and growth issues or delays, and then later in life, actually a higher incidence of behavioral problems in the development of mental health disorders. So not treating perinatal mental and behavioral health conditions has really long-reaching implications. We're going to turn briefly now to some Missouri-specific data. So I don't know if anyone on this call is familiar with the PAMR. This will be a really quick and dirty overview, but I do encourage you, if you're interested, just Google it and read it in a little bit more depth. It has really great data. And I also want to acknowledge that we are talking about maternal mortality here. It's a very heavy topic. Feel free, obviously, to mute your laptop at any time if you don't want to be, if you just need a break from the content. So the PAMR is the Pregnancy Associated Mortality Review. Missouri's PAMR comes out every year. The 2025 report came out actually just less than a week ago, so this is very fresh data. And it looks at every death that occurred either during pregnancy or in those 12 months postpartum in the state of Missouri. There is a PAMR review board comprised of multidisciplinary experts from around the state. OBs, psychiatrists, midwives, social workers. We have kind of that full spectrum of folks who interact with this population. And they look at all of these deaths in detail. They look at how high is our maternal mortality rate in Missouri, who is most impacted, what is causing these deaths, and how could we be preventing these deaths. So like I said, there's a lot of really important data within this report. I do encourage you to check it out. But I want to highlight a few of the key findings. So between 2018 and 2022, which is the window that this report looked at, Missouri had a pregnancy-related mortality ratio of about 32 deaths per 100,000 live births. That was for the overall population. That rate was 2.5 times as high for Black women in the state of Missouri. Really stark disparity there. Like I said, the board also looks at every death and determines what was the main underlying cause of this death. And they found that mental health conditions, including substance use disorder, were the #1 leading underlying cause of death for pregnant and postpartum moms in the state of Missouri. So suicide, overdose, that is what is killing most of our pregnant and postpartum moms. The board also looks at each death and they ask, could this death have been prevented? Was there an opportunity to intervene at some point? Could we have screened? Could we have gotten this person connected with treatment or medication or whatever resources? And could this trajectory have been different? Sometimes the answer is no. Not all deaths are preventable. Things happen, things come up. They couldn't have guessed that it would happen. But for every single one of those deaths due to mental health conditions and substance use disorder, they determined that the answer was, yeah, this could have been prevented. 100% were preventable. So this is, I think, a really heavy statistic. There are a lot of people who died who didn't need to die, a lot of children, families, communities that are impacted by this and will be for years and years to come. But I also do think that it is, cause for optimism, because we know that the #1 cause of death for pregnant and postpartum moms is something that we have the ability to completely prevent. And then I want to highlight just one more slide, one more finding from the PAMR. They look at these 3 different parts of the perinatal period. So during pregnancy, those first 6 weeks postpartum, and then 6 weeks to 1 year postpartum. And you can see that 6 weeks to 1 year postpartum is when mental health conditions take the lead as the #1 cause of death. So we know that during pregnancy, there are all these structured appointments with an OB. Obviously, not everyone is able to attend those, but a lot of women are being seen by a medical professional during pregnancy. In those first 6 weeks, there are going to be some follow-up appointments or pediatrician appointments. But then after 6 weeks, women can kind of fall off the radar of care professionals. And that is the highest risk time for folks struggling with mental and behavioral health conditions. So I just want to highlight that this 43 days to 1 year postpartum is a really vulnerable window and a really important window to be looking out for these new moms and continuing to check in and continuing to make sure that everything is going well. Okay, switching gears for just a second. We're now going to look at pediatric mental health in Missouri and some data around that. So again, a little bit of definitions to get us all on the same page. For the purposes of MO-CPAP in this presentation, when I say pediatric mental and behavioral health, I am referring to any mental or behavioral health condition that occurs during childhood, adolescence, or even young adulthood. So MO-CPAP covers kiddos up to age 21. Nationwide, it's estimated that 1 in 7 kids will experience a pediatric mental or behavioral health condition. And of those who do have one condition, 1/3 will have 2 or more. So there's a ton of comorbidity going on, which makes treatment and supporting these kiddos that much more complicated. It's also important to remember, like we talked about with perinatal mental health, these numbers are likely too low. We're likely not diagnosing everyone who actually does have a mental health condition. And so not all kids who experience one of these concerns will actually get a diagnosis. So the numbers are probably a bit higher than these slides suggest. This slide has data on children's mental health in Missouri specifically. These numbers are pulled from 2 different sources that I also recommend. They both have really great data. So the Missouri Institute of Mental Health's Suicide in Missouri report and the Annie E. Casey Foundation's Kids Count Data Book. So in the state of Missouri, among kids aged 10 to 17, suicide is the 2nd leading cause of death. Among young adults ages 18 to 25, it is the 3rd leading cause of death. About 16% of children between the ages of 3 and 17 in Missouri have a diagnosis of depression or anxiety, which again, probably a lot higher proportion of kids do have depression and anxiety and just haven't gotten that diagnosis. 1/3 of Missouri high school students reported being sad or hopeless almost every day for 2 or more consecutive weeks. So these are, pretty horrifying numbers. Our kids are struggling in the state of Missouri. And only 1 county in the entire state has an adequate supply of child and adolescent psychiatrists, or CAPs, to address the needs of its children's mental health. That is Boone County, which is where I am located. And even with us technically on paper having an adequate supply of CAPs, you have to consider there are so many rural counties sending kids to Boone County for medical care. There are still absurd wait times for kids to get in to see a specialist. So this map kind of illustrates how CAPs are spread out around the state of Missouri. The counties with H's in them signifies that they are health professional shortage areas in general of all provider types. There are only 3 counties in the entire state that have 20 or more child and adolescent psychiatrists. And as you can see, the vast majority of counties in the state of Missouri don't have any. So the point of this slide is to show that, as we've determined over the past few slides, we do have a serious public health problem in pediatric mental and behavioral health. And we just do not have the workforce that we need throughout the state to provide the care that these children need. So for both perinatal and pediatric mental and behavioral health, we know that they're super common. We know that they are really, really significant problems, nationwide, but in the state of Missouri specifically. And we know that we don't have enough specialist providers to provide the level of care or the amount of care that is indicated. So that is where the Maternal Health Access Project and the Missouri Child Psychiatry Access Project come into play. So what are MHAP and MO-CPAP? First off, we call them sister programs. So we work very closely together. We do all of the same things, just for different populations. We are Missouri's statewide psychiatry access programs. So psychiatry access programs are actually interventions aimed at providers and community professionals, not at patients directly. Our goal is to increase the capacity of the workforce that already exists in the state of Missouri to better and more confidently support their perinatal and pediatric clients who do have mental and behavioral health concerns. So our goal is to take the knowledge that is concentrated in just a few people in Columbia, Kansas City, St. Louis, and make that knowledge available to folks all throughout the state. As I said, we are a resource for providers and community professionals. We do not provide direct care to patients. So I'm going to probably hit that point home over the course of this presentation. But another point that I want to hit home is that all of our services are 100% free to both providers and to patients. So no charge for anything ever because of our state and federal funding. So that's a really exciting piece of this, and the same is true for Kansas's programs. So I'm going to use the word provider a lot throughout this presentation, but what I really mean is provider or community professional, anyone, anywhere in the state of Missouri providing healthcare, social services, other some sort of structured support to patients who are either pregnant, postpartum, or up to age 21. So this is not an exhaustive list of the type of folks who have registered for our programs. As you can see, we do have medical professionals, so different physician types, nurse practitioners, PAs, registered nurses, birth workers, doulas, midwives, behavioral health clinicians, social workers, therapists, case managers. Also, home visitors are a huge sector of our enrolled provider population, and community health workers. But we also have a chiropractor, we have physical therapists, occupational therapists. If you are working with someone who is in one of these two populations and you know them, you have a sense of if they're doing okay or if they're not doing okay, and you are in a position to help them, we want to help you to do that. So yeah, I'm going to say provider throughout, but it is a very, very loose definition of provider. So both of our programs have three main components to them, and I will talk about all of these in a lot more detail, but just a quick overview of what our programs actually do. So we are super fortunate to have a team of perinatal psychiatrists and a team of child and adolescent psychiatrists who staff a phone line for us Monday through Friday. So if you are working with a client and you're like, oh my gosh, something is wrong, but I'm not really sure what, is this normal postpartum? What is going on? You can request a conversation with our psychiatrists, and within as soon as 30 minutes, you can be on the phone with them. We also have a really wonderful care coordinator team. And if you have a client who you think does need to be connected to a psychiatrist or a therapist or substance use disorder treatment, they can actually work directly with your client to make that connection and provide a very warm handoff, and then continue reaching out to make sure that it was a successful connection and that it's working. And then finally, both of our programs have a humongous emphasis on training and education. So we want to create materials, offer webinars that are going to provide folks throughout the state with really helpful, usable, actionable information on what these conditions are and how to best support pregnant, postpartum, and pediatric folks who are struggling with them. So if you are like, okay, great, I want to talk to a psychiatrist right now, how do I do it? We're going to do a very thorough step-by-step to go through that process. So we do ask that before utilizing our services, professionals sign up, fill out our registration form. We have one registration form shared between both programs, so you can sign up for both programs at one time. You can either scan the QR code or go to that URL, and I am also happy to email links out to anyone who is interested. The registration process takes about 5 minutes. We do ask that folks register individually. We don't let agencies or doctors' offices or practices sign up for everybody. So everyone does need to sign up individually. And I'm going to leave this up here for just a second in case anyone wants to scan and sign up. So as soon as you fill out the registration form and press the submit button, you will get an email. And that email will have our phone number and a link to our online intake request forms. So if you did want to have a psychiatric consultation, you can either go to that online form or call our number. Our phone line is actually staffed 24/7. So Behavioral Health Response out of St. Louis runs our phone line, and they are one of the state's 988 centers, and they can take your call any time of day. So if it's like 3 a.m. and you can't stop thinking about this client you saw and you're like, okay, I just need to schedule this right now before I forget, you can call and get that consultation scheduled anytime, day or night. We will ask you for your direct callback number as well as the time that you want your call. We have slightly different hours, but we're both available 40 hours a week. So MHAP is Monday to Friday, 9 to 5, and MO-CPAP is Monday to Friday, 10 to 6. So you'll select your callback time, give us your phone number. We recommend, if you have maybe questions about medication, that you have that person's medication history on hand, or if you've administered a screening, it would be helpful to have those results on hand. But if not, no worries. So at the time that you've chosen, our psychiatrist will just call you directly. And then you have your consultation. It's based on the curbside consultation model. The idea that if you were working in a building with a bunch of other professionals and you had a perinatal psychiatrist a few doors down, you could just pop on over and be like, hey, saw this mom. I think she needs, I don't know what she needs. This is freaking me out a little bit. Help, what should I do? You could just kind of have that conversation with a colleague. So this is designed to kind of replicate that, but over the phone, statewide. So just conversation among colleagues to figure out how to best support your patient, your client. Consultations have been as short as 5 minutes. They have been as long as almost an hour. Our psychiatrists really want us spreading the message of no call too small. So any question that you have, however like insignificant or dumb or basic it might seem, it's not. Please request a consultation, talk to the experts, get their wisdom. And then you don't need to worry about taking notes or anything. After the consultation, you will get a call summary sent to your email. It will go over everything you discussed, and the psychiatrists like to link to resources that they think might be helpful as well. So especially for folks who aren't prescribing medication, it can be kind of hard to understand, like, why would you want to go talk to a psychiatrist? So the next few slides are going to review the kind of consultation calls that we have been getting. So on the MHAP side, these are pretty much all medication questions. And another kind of soapboxy thing that I like to share when I have, just an audience of anyone who's listening to me, there's kind of this myth that all psychotropic medications are unsafe during pregnancy, that if you become pregnant, you should stop taking your meds, not good for the baby. And the picture is actually a lot more complicated than that. As we saw, there are really serious risks associated with not treating your perinatal mental and behavioral health conditions. So just as you go through the world, if you have a patient, they get pregnant, they're like, I have to go off my Zoloft right now. Maybe just, don't help perpetuate that myth and maybe encourage them to talk to their doctor. But that's a tangent. So if you are prescribing medication, we can help you figure out what medications are safe during pregnancy and breastfeeding. How do you conduct a risk-benefit analysis to decide what, if any, medication you should take? Which medications are safe during pregnancy? How do you dose, titrate? And if someone does want to go off their meds, how do you safely wean them off? And then this bridge care piece I will talk about in more detail once we get to the MO-CPAP side of things. Still on the maternal side, I do really like to note that of our 3 perinatal psychiatrists, 2 of them are board certified in addiction medicine. So if you do have a mom who has a substance use disorder and wants to seek treatment, or maybe is already on methadone and gets pregnant, they can help you figure out how to safely initiate or titrate medications for opioid use disorder during pregnancy. Or if you have a mom with a history of a substance use disorder and then their pain management needs during labor and delivery, how do you safely manage that? How do you balance that? If she has a C-section and she's sent home with all of these pain medications and she's really freaked out about it, how do you help her? Our psychiatrists can also talk through different harm reduction techniques. If, not taking a substance is not an option, what are strategies to reduce harm? Treatment for other types of substance use, alcohol use disorder, nicotine use, and then also any lactation considerations. So on the MO-CPAP side, if you had a child or adolescent client or patient, and you maybe want to know, how do I even screen? Like, how do I decide which screener is appropriate? When do I use it? How do I administer it? How do I open up this conversation? If you have a kid who doesn't want, or maybe isn't, medication isn't indicated, how do you plan out their non-pharmacological treatment? Our psychiatrists can help with diagnostic clarity. So what does this child actually have? What are we actually dealing with? Like I talked about on the MHAP side, they can talk about different medications, risks, benefits of different medications. They can help you review whatever medications the patient might already be on. They can talk through dosing, titrating, weaning different psychotropic medications. But then also sometimes a higher level of care or specialty care is necessary. You do need this kiddo to actually get in with the child or adolescent psychiatrist. And the wait times for that can be awful, can be like 3 to 6 months to see somebody, and folks can't wait that long. That's too long to be struggling without support. So in the meantime, while we're working on our care coordination side to get them in with a specialty psychiatrist, we can help you start bridge care. So we can help just kind of figure out how to best support them in this interim period before someone else can kind of take the reins. There is no limit to how often you can call MHAP or MO-CPAP in general or about a specific client. So if you see a client one week, you call us, we give you a recommendation or a suggestion, you implement it and you're like, nope, that was not it. Just call us back and we can keep working with you on the same case for as long as it takes. And then for folks who aren't prescribing medication, I'd say like half of our registered providers on the MHAP side are not prescribers. So if you are someone who is administering a screener like the Edinburgh postnatal depression scale, and you do get a positive result, or maybe it's not too high of a score, but you're concerned about some of the answers, you can call and talk to our psychiatrist about, okay, here's what I'm seeing on this Edinburgh. What now? Like, what does this mean? If your client got a diagnosis from someone else or is struggling with a set of symptoms, how do you help them understand it? How do you talk them through that? If someone does have a mental or behavioral health concern, what's the most appropriate next step? We've gotten calls from home visitors throughout the state who are like, this seems bad, but I don't know if I need to, like, do I call 911? Do I call 988? Do I make them go to the emergency room? Is it that serious? So our psychiatrists can help you think through those kinds of questions as well. So if you have any questions at all about how to best support your client or advocate for your client, give us a call and we can help you think through those. I talk way too fast usually, so I'm also sorry if that's happening right now. I have a giant note that says slow down in front of me, so I'm gonna try to do that. Moving on to our resource and referral piece, the care coordination piece. This slide is not the most intuitive, so I will go through the left side and then I'll talk briefly about the right. So if you do have a client and you're like, okay, they need someone who, they need specialty care, they need a psychiatrist, a therapist, substance use disorder treatment, we have a really wonderful care coordinator team who can actually work directly with your client to help them get connected to those services. So if you do want care coordination support, you can just go to that same online form or call the same phone number. We ask whether your client has agreed to be contacted by us. So we don't have a formal consent form that we need filled out or anything like that. It can be as simple as you're talking to your client and you're like, okay, I think you could benefit from someone helping you get connected to X, Y, or Z. There's this organization called MHAP. Is it okay if I give them your name and number so that they can help you find a psychiatrist? And if they say yes, that is good enough for us. So you'll go to the form or call in, you'll indicate that they're okay being contacted by us. We will ask for additional information. So we'll ask for their age, any diagnoses or symptoms you're concerned about. We ask for insurance type, and that's just to make sure that we are connecting them with accessible resources, not because we're going to bill them for anything. And then of course we ask where they're located. So something I do want to point out, I think I mentioned earlier, the provider does need to be located in Missouri. But if you were in Kansas City, Missouri, and you are seeing a patient who lives in Overland Park, that's fine. We can help. We can still help because it matters where the provider is located, not the patient. And we do have a very strong connection with the Kansas program, so we can also work with their care coordinators to find appropriate resources. So if you're based on the Kansas side, go to KCC. If you're based on the Missouri side, come to us no matter where your patient lives. So anyway, we will ask for all of that information. Our care coordinator will do their research. They'll see what options are available. They will call and make sure that wait lists aren't crazy or that someone is currently accepting more Medicaid patients or things like that. And then once they've got a list of viable options, they will reach out to the patient directly. They'll give them a call. And that happens within 48 hours. So on the child and adolescent side, if it's for like a 7-year-old kid, we'll obviously be calling the parent or guardian. We're not going to be trying to coordinate this with the child. And then on the perinatal side, we will be working directly with mom. So our care coordinator will give them a call. They'll say, hey, I heard from your therapist or whoever that maybe we need to get you in with a psychiatrist. I did some research. Here are some options. Do any of these sound good to you? And once the client has said, yep, I think that one's the best fit, the care coordinator will ideally make a three-way call right then and there and get that appointment made with the patient on the phone. So we try to make it as warm a handoff as possible. We are not trying to be like, oh, you're a new mom with a baby and you're really struggling with depression. Here's a list of numbers for you to go call in your free time. We want to make it as supportive and hands-on a process as we possibly can. So we make sure that appointment gets made, and then our care coordinator will continue to follow up with the client or the family on a weekly basis until we've made sure they've connected with services, gone to at least 2 appointments, it's a good fit, and they feel good about the connection that has been made. Also, sometimes people are like, I'm so busy, please just send me an email, don't call again. We do that. We're not going to be like harassing your clients if you give us their phone number. And then once they have either told us to stop calling us or they have been able to attend at least 2 appointments, all is going well, we'll close out the case, we'll stop the follow-up. But if anything happens in the future, if they're like, okay, the therapist isn't working for me anymore, you can reopen another case and we will help them find somebody new. So on the flip side, on the right side of this chart, if your patient really does not want their contact information shared with us, totally fine, no problem. Our care coordinator will go do the exact same research, but they will just contact you directly and share that list of options with you, and then you can share it with your client. These are the services that we have most commonly connected patients to. So we've helped folks find primary care providers, psychiatrists, different maybe specialty therapy or group therapy. Especially on the perinatal side, there's actually a really incredible library of online virtual totally free support groups out there. So if someone lives in an area that doesn't have that many resources, because we obviously can't like create resources, we can help them find options that may exist online and help them get connected there. We can also get folks linked up with the really amazing home visiting network that we have in our state. So again, not an exhaustive list of services, but this is what we most commonly receive requests for care coordination to connect patients with. Okay, and then finally, the training and education piece. And I'm always so excited to tell people about this because all these resources are just available online, ready for you to access whenever. So every professional who registers in our program will have immediate access to all the materials that we generate. Everything is available for free on our website. You can download, you can print, you can share. It's there for you to use however is helpful. MO-CPAP has been around since 2018, and they have a really robust online resource repository. And that includes actually an online library with 12 pre-recorded webinars on a variety of topics related to pediatric mental health. These webinars are actually CME eligible. So if you do want continuing medical education credits, you can view the webinars asynchronously, fill out a form, and we will get you that CME for free. There are also a bunch of other resources like diagnosis flowcharts, decision trees for medications, resources that you can share directly with parents to help them understand their kid's diagnosis, and that is not exhaustive. So once I'm done presenting, I'll put our websites in the chat, but on the MO-CPAP Resource Hub, you can filter their library by a bunch of different things. You can filter by diagnosis or by audience. So do you want something that you can give directly to families or caregivers? Do you want something for yourself? Do you want something to give to a doctor? And you can filter by type. Do you want a webinar? Do you want a PDF? Do you want a handout? Something like that. So I highly encourage everyone to check out this resource hub if you have any questions at all about mental or behavioral health in the pediatric population. There are probably some really relevant resources there. Oh, and then the other thing I should have said, MO-CPAP offers monthly live webinars. So yeah, they occur every month. They are all held virtually, and there are continuing education credits available for attendance at no cost. So that is something to know as well. And then MHAP, we are a newer program. We just hit 1 year in April. And right now we are offering webinars on a quarterly basis. So like with the registration form, MHAP and MO-CPAP share a training registration form. So if you were to scan that QR code or go to that URL, it would let you sign up for both our trainings and MO-CPAP's trainings. So I do want to highlight the training that MHAP has coming up this month in July. It is 3 hours of content, so we're splitting it up over 2 days. The Addiction Policy Forum created this really comprehensive 3-hour training on addiction and anti-stigma and how to respond to addiction in a way that is not harmful, evidence-based, productive. We're really lucky on our team to have Catherine Miller. She was trained to give this presentation in Missouri, so she's kind of like the state's go-to person for this content, and she will be leading this training July 29th and July 30th. Continuing education units are being offered at no cost for folks who attend live. Most of our trainings are offered, are recorded, and then you can view them later on our website. This one we will not be recording because it is proprietary content of the Addiction Policy Forum. So if you are at all interested, I encourage you to sign up and join us live later this month. Okay. Yes, I will send all information about the trainings. I'll send all links in the chat as soon as I'm done presenting. MHAP also produces, we're in the process of creating a lot of resources for both providers, professionals, but also patient-facing resources. So this marijuana one has been kind of a hit. So if you have a mom who's like, yeah, my morning sickness sucks and smoking weed is the only thing that helps, and you're like, that doesn't sound great, but I don't know how to talk to her about this, give her this flyer. It can at least start the conversation. We review all of our patient-facing materials with health literacy principles in mind. We have a therapist who works with this population kind of give us some intel on the lingo that we could use to make it seem more accessible and we're like, we know what we're talking about. So we've got this one on our website available for download. We're working on one about the impacts of secondhand marijuana smoke on infants and children. And then we also, our psychiatrists put together a 3-part series of flyers on different medications for opioid use disorder and how to use those during the perinatal period. So these are, I think, really helpful little bite-sized intros. We have buprenorphine, methadone, and naltrexone. And they just are kind of like an introduction to make it seem a little bit less scary to be prescribing these medications to women during pregnancy and lactation. So again, all available for download on our website, and I will give you that link in a little bit here. And then in our last few minutes, I want to talk a little bit about the impact that we've had so far. I have too much fun with Canva, so when we turned 1, I made us this little birthday card. And over our first, I guess at this point, 15 months, we have signed up 561 providers and professionals from 60 distinct counties. I'm happy-ish with that, but that's out of 115, and we would like to see 55 more counties represented here. We have done 68 provider-to-provider psychiatric consultations, and our care coordinators have worked with 96 pregnant and postpartum moms throughout the state to get them linked up with services. I can talk all day about how valuable I think these consultations are, but I wanted to include some feedback from folks who have actually used our services. So after every psychiatric consultation, we ask what was helpful about the call, and we also ask for, what wasn't good about the call, what could have been better. But I wanted to share some of the responses we've gotten to that what was most helpful about the call question. These responses represent a variety of provider types. So we've got an OB, a family medicine doctor, a therapist, and a home visitor here. And I will not read through these, but I will just leave these up for a second because I think that the experience our providers have had with a psychiatrist kind of speaks to how accessible and helpful of a resource this can be. So then turning to MO-CPAP, MO-CPAP, like I mentioned, has been around for 7 years now, which is amazing. Launched in 2018. So far, over 900 providers throughout the state have registered, and this kind of blows my mind. Almost 2,000 total families have been supported through MO-CPAP services, either through care coordination, psychiatric consultation, or both. And then to that end, MO-CPAP made a really wonderful video a few years ago that I am going to play for us that you hear directly from folks who have used it about how it has supported them and how it has been a valuable resource as they work to support children and adolescents. So I'm going to stop sharing real quick and then try again sharing sound. And then hopefully this works smoothly, but please let me know if not.
I think as physicians, as pediatricians, we always want to have the answer. We want to be able to fix things. So we have patients that we have gotten to know that as we see them struggling more and more with their mental health, what you might have felt comfortable helping with prior, all of a sudden you're feeling more out of your comfort zone. And so you reach the limits of what you feel like you can help them with. MO-CPAP allows you to have somebody to reach out to say, here's what's going on, what can I do next?
The Missouri Child Psychiatry Access Project is really an attempt to help and serve youth who have mental health issues with the shortage of child psychiatrists. And many primary care providers, when they go through their training, they may not have a lot of exposure or education on mental health. So the benefit to MO-CPAP is that when you feel or if you feel uncomfortable and you need someone to help you work through how to assess and treat, you can call our number, talk with a child psychiatrist, and get that right away. We actually provide one-on-one consultation with primary care providers within a 30-minute window. We provide educational modules that are online that they can go and they can do and learn more about screening tools, diagnosis, and treatment of common psychiatric disorders. And then in addition to that, there's linkage and referral. So if they, through either talking with a psychiatrist or they themselves know this child needs therapy, we can help refer them and link them to someone who can do the therapy. We've been able to add support coordination so that there's a coordinator who connects with families to make sure that they were able to get the resources that they needed.
For me as a rural provider, it really is a lifeline. It's my ability to get expert advice quickly, conveniently for my patients. We're very, very isolated. Many patients travel 60 miles of not so good roads or even longer to come see us for routine medical care. It's challenging for families. Oftentimes they try many, many things at home first, and when they finally make that decision, gosh, we've got to go see the pediatrician about this, they're close to the end of their rope. Many times if I do refer a child for child and adolescent psychiatry, it may be months before they have an appointment. Many families are not ready to wait 6 months anymore. Many families want an answer yesterday and they finally got brave enough to ask today. Once they make it to my office, they're hoping and praying for some sort of answer, some sort of resolution to the issue that they're dealing with. So having MO-CPAP child psychiatrists to help guide me really is a lifeline for both me and my patients.
MO-CPAP is really invaluable. I can't really think of a price I would put on it because it's just so critical. A lot of the patients that we serve, many are living in poverty. So we often have patients come to us that are in crisis, that need immediate intervention, and psychiatrists that we might want to try to refer patients to, they unfortunately may not accept Medicaid, and our patients certainly are unable to pay out of pocket. And so for us to be able to utilize MO-CPAP to get recommendations regarding medicine or to get them these interventions that they need here with providers that they already trust, it's just really invaluable, and everybody needs to know about MO-CPAP.
What I wish people knew about MO-CPAP is that it's so very easy to use, that I can schedule a call, that I can say, can somebody call me at 5:15 today, or can we do it first thing tomorrow morning? And I'm able to really devote time to that discussion.
I was so happy after the first time that I called because not only did I have one answer to that question, but then I had a plan B, C, and D on the what ifs, because we all know the what ifs happen. It's nice to know that down the road we have multiple options. And so I wish people knew how easy it was, how fast it can be, and that it's free.
Having access to the training modules, to the consult line. It really does bolster the confidence of our providers in being able to manage the patients when they come in with these conditions. It really helps in building that competence and that confidence.
And so when you're able to turn the corner with a teenager who's been struggling with depression, with anxiety, the first time that you see them back for a repeat visit and you see that light in them again and that sparkle, there are few better feelings that I've had as a pediatrician, and just getting to talk to them again about the things that they love and seeing that also in their parents' faces, and you know that they've really gotten their child back. It's one of the most rewarding feelings that I've had as a pediatrician.
Okay. Well, I hope that worked and y'all could hear everything. I'm going to skip over these. That, once more, is our registration link. And I will put this in the chat when I stop screen sharing. And then I wanted to leave about 10 minutes for questions, so I think that's perfect.
Thank you, Elena. Great presentation, but really sad to hear just how much of an issue this is. So the floor is open for questions. If anyone has a question, feel free to drop it either in the chat or the Q&A down at the bottom. And in the meantime, I will go ahead and put the link for your certificate of attendance in the chat as well, along with the password to access it. So you are welcome to do that as well.
That's the link to register. It's the link for our trainings. That's MHAP. Thank you for bearing with me. And then MO-CPAP. And if you go on this MO-CPAP page to the resource hub, that's where you can find all the different resources and the filters, and yeah, all available for download.
All great information. It's such a critical resource. Any questions?
Yes, absolutely. Please feel free, if you have any questions, if you want anyone else to know about these programs, please feel free to reach out, share my information with anybody. Thank you, Celia. That's really great to hear.
While we wait for any additional questions, I do want to make a quick plug that this webinar was recorded, and so you will be able to access it on our website, mentalhealthkc.com. And then coming up in 2 weeks on Thursday, July 24th, we will have another webinar from noon to 1. That one is going to be focusing on back to school and helping kids navigate some of the relationships, the bullying that goes on at schools. So you're welcome to come back for that as well.
So I see Candace's question in the chat. Am I at all concerned about changes in the funding landscape could affect us? So that's a really good question. And candidly, we were really worried for a while. But on the maternal side, which I can speak to a little bit better, we have funding through HRSA till 2028, and we feel very confident that we will keep that. But actually the bulk of our funding comes from the state of Missouri. We're a line item in the governor's budget. They have continued to renew our funding at the same level. And maternal mortality is a really big, reducing maternal mortality is a really big priority for the state, and they have been very committed to funding these services. So yeah, I was worried, but right now I think we're fine for at least 2028. I think we'll be good to go and continue providing these services. That's
fantastic news.
It is, yeah. It was. weren't sure, but it's been really great to see actually the commitment to perinatal and pediatric mental health.
Absolutely. Any final questions? Got a couple more minutes. Thank you all again for coming and joining us as well. We appreciate you being here, and I'm sure that I speak for everyone on this call when I say thank you, Elena, for sharing all of this information with us.
My pleasure. Thank you so much for giving us the opportunity to. Really appreciate it.
Absolutely. We will leave this open for another 4 minutes or so. So if you have any questions, feel free to ask them. Otherwise, we hope to see you back here for another webinar on July 24th.
Did the video sound work okay, Kayla?
It did.
Phew, okay. It's almost so dicey.
I know. Every time that I have to try and share a video via like Zoom or Teams or something like that, I'm like, this isn't going to work. But yes, your video and audio came through.
Wonderful. Okay. I'm not a technology girl.
Me either. I have an IT team for a reason.
Yeah, 100%. Every time I'm trying to get my dual monitors at home, I have to call my husband and he's like, you've done this so many times. I'm like, yeah, but only one of us needs to remember.
Exactly.